attended one of our education sessions before can just give us a thumbs up. Amazing. And you can either show that if you're on video or just send a thumbs up reaction. Perfect. And then we'll do a really quick chat storm. So a chat storm is really where you type an answer in the chat and then you wait to send until we've said go. So I would just ask maybe like on a scale from 1 to 10, how confident do you feel with giving family-centered care? There are challenges with it. So I wouldn't say any of us are a 10. Even us giving this presentation, I would never say I feel like a 10 out of 10 confident in terms of navigating all the dynamics of family-centered care. So maybe just type in the chat if you're comfortable sharing where you feel like you fall on a scale from 1 to 10 with confidence with family-centered care. So we'll hold those responses. And I'll give you about 15 seconds before I get everyone to post. And Monica's ahead of the game. Perfect. So 3, 2, 1, go. Feel free to send those responses in. Perfect. Yeah. Thanks so much for sharing, everyone. And a really big mix across the board. I think with some of you coming from more teams that see more adults, you might be starting to see some of those transition-aged youth, 18 to 24, and others of you might be on some dedicated child and youth units or teams. So that's really helpful for us to see. Great. Just coming into the session today, before we begin, we want to acknowledge that we are coming off a long weekend dedicated to celebrating the value and importance of family. And we cannot talk about family-centered care without acknowledging the impact that historic marginalization of Indigenous communities in Canada has had on their family units through such inhumane measures as the 60s scoop and decades of residential schools. As clinicians who are aiming to provide family-centered care and support family resilience, it's very important we're aware of these historic injustices that are still having impacts today. We must continue to work on decolonizing healthcare and demanding more from the systems we work in to ensure that every family can thrive in Richmond. A small but not insignificant part of reconciliation is acknowledging the land that we operate and live on. And so we want to acknowledge today that Richmond Hospital operates on the traditional, ancestral, and unceded territories of the Coast Salish peoples, Musqueam, Squamish, and Tsleil-Waututh First Nations. Acknowledging that these lands have been spaces for living and learning since time immemorial, and we are very grateful to be guests on this land today to continue learning together. So today, we hope that by the end of our session, you'll be able to identify the value of including family in treatment, as well as talk through some of the barriers that make that hard, even though we know it is valuable, to review privacy policy documents and clinical practice implications, to demonstrate comprehension and application of privacy policies, for example, when confidentiality may be broken and what would appropriate next steps be, identify strategies to engage with families and caregivers, and identify strategies to work through resistance or challenges with family. So I'll turn things over to Steph to get us started.
All right, everyone. Hi, I'm Steph. I will be talking to you about family-centered care, why it matters, and going through some confidentiality topics and privacy topics as well. So before we start, we just wanted to provide a definition for the purpose of this education, because of course we know that family means different things to everyone. So family-centered care, a quote that we like that is used by one of the my nursing instructors from Douglas College was, "A family is whoever a patient says it is." So family-centered care is a mutually beneficial partnership where family is included as a valuable part of the care team. This may include involvement in assessment, education, decision-making, discharge and safety planning, and resource connections for their loved one. Anyone that the patient or client has identified as part of their care team is referred to as family throughout this presentation. So this can include, but is not limited to, a parent, a guardian. Examples of a guardian would be an MCFD social worker, a parent-appointed guardian, or a temporary guardian, a friend that is over the age of 19, extended family members, dependents, so children of the patient over the age of 19, a partner or a sibling. So for the purpose of the older than 19 definition with the stars there, we are referring to family and friends over 19 with the purpose of completing paperwork. So when we're nominating a near relative or a notification of certification, we do legally have to have somebody over the age of 19. However, we do encourage involvement of friends or family members that are under the age of 19, but just for the purpose of completing any paperwork, we do need to ensure that they are of majority age. All right, so why do we need family inclusion, and why does it matter? So we know that involving family members as a key part of the care team can lead to improved patient outcomes. It can cause more culturally relevant and sustainable interventions. It reduces the need for future utilization of healthcare services. It increases family awareness on how to support and reinforce their family members' recovery. It improves patient and family coping skills, reduces caregiver burnout and burden, increases social supports for patients, and increases the likelihood of returning for necessary treatment due to a positive client and patient experience. So this is something that we briefly touched on in the first session about the importance of people voluntarily seeking services. And so family inclusion is one of those things that we can do to avoid involuntary certification in certain circumstances. Okay, so a question for the group, and feel free to, like Sarah said, throw it in the chat, put your hand up, or just shout it out on speaker. What are some barriers you have encountered to providing family-centered care in your practice? So Janice says cultural barriers. Yeah, so that can be a huge challenge if it's not a culture that you're overly familiar with. Yeah. Melissa says client declining to want to share information. Yeah, that's a huge one, especially for young people. I don't want anybody to know I'm here. I don't want anybody to know why I'm here. And that can make things really challenging. Monica says working with adults not granting permission to speak with family due to estrangement. Yep. Denise says client changing mind about involvement. Yeah, that often happens, right? It's not just a one-time conversation. Often you do have to have that consistent conversation and ensuring, hey, is it still okay that we do this or share this information? No, who can I share this information with? Margot says client does not want family involved and see them as an issue. Yeah, this is something that comes up really often. This can be due to family dynamics, or sometimes it's more related to their mental health diagnosis. So I know an example that gets brought up a lot is, we have a young person who's having a psychotic episode and they say they don't want anybody involved, but we know that their family should be aware of what's going on because they're going to be returning to their care. Yeah. And then Bryce says strict confidentiality for young adults. Yep. And Chandra says client has a lack of clarity about how they want their family members to support. Yeah, so sometimes they don't even know that there's different ways that we can go around confidentiality. There's certain information we can share, but there's a lot that we keep confidential. So making sure that they can ask those questions about what will be shared and that that's talked about before we go into our assessment. Yeah, exactly. And I'll get Sarah to press next on here. So there's a lot of these things that were brought up, but I think one of the biggest ones is time. So I know in acute healthcare settings and in the emergency department, where I have most of my experience, that often we are under a huge time constraint to get many, many things done. And so sometimes family-centered care falls by the wayside just because we are limited with time. There's also hesitancy of young people to involve their family in care. They want a sense of privacy. They don't want to share that information. There could be some interpersonal conflicts between families, so some family dynamics, different goals, values, and beliefs within family regarding treatment. So maybe a young person is willing to seek out certain treatment, but parents are not agreeable to that treatment or not on board, and the young person does rely heavily on their parents for their support. Patients who lack a strong support network or whose main support network is not local. So think of families where they're coming here possibly for school, or they're a first generation immigrant and most of their family is back home. So differences in biological age and developmental age or independence. physical or intellectual disabilities, COVID-19 impacts, and societal and cultural impacts. So some youth in their 20s and 30s are now still living at home and remaining more dependent on parental support with IADLs like finances, making appointments, and living skills, just due to the current culture that we're in with inflation and the housing market. We're seeing this much more often.
Yeah, and in relation to the COVID-19 impacts, we're referencing the fact that there has been some observation by clinicians and in school settings that some children and teenagers and young adults that have been in COVID are now potentially a few years behind in terms of a usual developmental stage because of missing out on some of those really key traditions, those key like social impacts that they would have had, for example, first year university being fully online. And so add some complexities into that as well.
Okay, so I'm moving into privacy policies. So the three that we're going to cover here are the Infants Act, FIPPA, so Freedom of Information and Protection of Privacy Act, and the Mental Health Act. So I know that this can this might be review for majority of people. It is an obligation that we do have an understanding of these while we're in practice, but I do just want to highlight some of the really specific things to mental health care, especially with this age population as well. So although I know everyone is probably aware of all these different acts, we do just want to touch on just a couple different aspects of them that you might find helpful to know when you're trying to decide whether or not to disclose information or what you can and can't share. So the Infants Act is an act that covers anybody up from the age of 0 until 19 less a day, so under the age of 19. So under the law, healthcare providers are responsible for two things. So assessing the capacity of a minor, so anybody under the age of 19, to consent to treatment, and determining whether a treatment is in the best interest of that patient. So for the purpose of the Infants Act, majority of these two things are often done by psychiatrists, family doctors, like actual physicians. But we do, as nurses, allied health professionals, peer support workers, we do have the input to provide that information if we are concerned about these two things. So where a healthcare provider assesses a young person to be capable and concludes that the treatment is in their best interest, the young person alone has the authority to consent or to refuse treatment. So some examples in situations that this may arise where a parent is saying no to a treatment, but then a young person is deemed capable of making a decision, is something like an immunization. So if a parent does not want their child being immunized or a young person being immunized, they do have the ability to make that decision. Other examples are gender affirming care, as well as blood transfusions. So moving on to the Freedom of Information and Protection of Privacy Act, it's a mouthful, so I will be calling it FIPPA from now on. So some of the clinical practice implications under FIPPA are that in BC, public healthcare bodies such as hospitals, health authorities, and the Ministry of Health are subject to the privacy protective measures contained in FIPPA. FIPPA guarantees the rights of individuals to gain access to and request correction of personal information collected about them by public bodies. So this is when a patient has been discharged from the hospital, they do have the right to access their medical records, and that includes their mental health records, as well as any of their certification documents. They also have the right under the Mental Health Act to request their certification documents in the moment, but I'll go into that in the next slides. But just know that everything that we document is allowed to be accessed by patients after discharge. There is some circumstances where certain information is left out if we're using people's specific names or co-patients' names, which should not be documented, but those will be blacked out by the people that are looking after our records. So it also prohibits the unauthorized collection, use, or disclosure of personal information by public bodies and requires that reasonable safeguards be put in place to protect personal information. So not anybody can just go and access these records. They are all now online. And so there is an obligation of health authorities and the Ministry of Health to protect people's records because this is some of the most sensitive information that we have access to. So we do take it quite seriously. And it's important that we know that and that patients know that as well. So some of the practice implications, so this is specific to anybody who is completing involuntary or voluntary paperwork under the Mental Health Act. So these are more so related to nursing or social work considerations, but it is important for allied health to kind of understand the concepts and what the paperwork is outlining. So for the Mental Health Act of BC, in this standard, the phrase third parties refers to family members, friends, and relatives of the patient, as well as guardians, representatives, and committees. So this is where that 19 plus comes into play, where somebody has to be over the age of 19 to participate in any of this paperwork or authorization. The Mental Health Act authorizes the disclosure of some personal information to third parties. So some examples of this would be the director must notify the near relative not nominated by the patient of the circumstances. And then if the director has no information about the identity of the person's near relative, the director may send the notice to the public guardian and trustee for involuntary certification. So this is something, if you're not aware, with the new Form 4s and the 4.1 and 4.2, there has been a lot of research done into and looking into the way that we fill out Mental Health Act forms. Unfortunately, we're not doing that great of a job in the mental health care field. So they have kind of more strict alignments with filling out these forms and ensuring that somebody is notified of certification. Every hospital does have access to a Mental Health Act clinician, and Richmond does have one. So if you do have any questions, you are able to contact them about completing forms. But that, like I said, is specific to anybody who is signing this paperwork. So usually that would be someone, depending on what the unit makeup is, but usually it's someone like a patient care coordinator, head nurse, charge nurse, and they would be considered the delegate in those situations. So it's usually a nurse or a social worker can do that as well. All right. So some further clinical practice implications for everyone, not just nursing and social work. So there will be circumstances where it is necessary to release personal information of the patient without the consent of the patient or despite the refusal of the patient. So some situations or examples of this would be a child. And when we say child, we are meaning under the age of 19. A child is in the care of the director, so MCFD, under the Family or Child, Family and Community Services Act. Voluntary and so a quote related to this is, in this case, it may be necessary to disclose the fact of the admission to the director since children in care are generally more vulnerable and will require more and different services from the director of MCFD as a result of the illness giving rise to the admission. So essentially what this is saying is that it's important if a child is under the care of the ministry, that their MCFD social worker or somebody from the ministry is aware that they are in hospital. Another example of a situation where we would have to breach confidentiality is that a child is admitted under the Mental Health Act, so voluntary or involuntarily, and the child is not accompanied by their parent and does not nominate their parent as a near relative. A patient is being released from the designated facility into the care of a family member, and it is necessary that a family member have relevant information about the medications prescribed to the patient. So this is something that's really important when we consider the age of someone. So this is not necessarily just for a child under the age of 19. If you have a patient that is 22 and living at home with their parents and they rely heavily on their parents to provide care and support to them, and they're heavily involved in their treatment plan and their care, there are circumstances like sharing information about medications, side effects, relapse symptoms that parents would need to know in order to provide adequate care. So that comes under continuity of care, which I'll discuss in the next slide. A family member has indicated to the clinicians that they are fearful of their relative who was admitted under the Mental Health Act because the patient has threatened them in the past. So we do know that if there are any safety concerns or threats made towards any specific persons, that we are obligated to ensure that those persons are notified of that threat, as well as making sure that there is contact with police if we're talking about more severe threats. Right, so confidentiality, so clinical practice implications for patients and families. So we're going to go through different situations that require confidentiality. And so we did find some articles on something called the traffic lights for disclosure. So I did find it as kind of like a helpful reminder about when we can share and when we can't share, and then some of those gray or yellow areas. So for the purpose of this conversation, red is going to be may not disclose. So this is a situation where we would never disclose. Yellow is something that we may disclose depending on the circumstances or the nuances. And then green is something that you must disclose. So for the red light disclosure, FIPPA and PIPA, another term here, so Personal Information and Protection Act, do not outline specific situations when you cannot share information. We can work backwards from authorized disclosures to conclude that the disclosure is usually not authorized if the disclosure is not for the purpose of continuity of care and disclosure is not mandated by law. So what this means is, in other words, the individual requesting the information does not have the right to have it. So when we're talking about continuity of care, we usually will think between care providers, so from case manager to case manager, physician to nurse. But for the purpose of continuity of care, in the example that I provided before, is that if you have a family member that is providing direct care to a patient and they are required certain information to understand what is going on with them. So usually this is something to do with medications, relapse symptoms, side effects of the medication, what it looks like when the medication is working or when it isn't working, especially when we're in the process of switching medications or titrating off and increasing another medication. So that falls under continuity of care. So another example of a situation where you would not be authorized to disclose is that you are disclosing more information than the person you're disclosing information to needs to know. So generally between clinicians, we do expect that you are providing all the necessary information, but when we are talking to family members or friends, keeping in mind that we only want to be sharing information that is on a need to know basis. Do they need to know this information in order to safely look after this patient at home? If it's something about their substance use, that's probably not something that they would need to know. Sexual activity, things like that, that's not something they would need to know, but something about their medications or discharge plan or follow-up plan is likely something that they would need to know in order to support them getting to their appointments. So another situation where you would not be authorized is if the patient did not consent and the information is not required to provide care or services. So that really comes back to something like substance use, sexual activity, what they're doing with their friends on the weekends, that kind of thing. An example of a red light disclosure would be disclosing to a parent that their child is sexually active when the patient presented to hospital for depression. So just a situation where across the board, you likely would not need to disclose that information. So I'll pause there and just see if anybody has any questions. Please feel free to shoot your hand up or even throw it into the chat. We're not easily distracted and we don't want you to forget your questions. So if you do have any questions, please feel free to stop us and ask at the time. I know this is a lot of information to take in. And also just a reminder that we will be posting the recording as well as the slides for later viewing if needed, if there is anything that you missed or want more information on as well. Great. Awesome. Okay, so we'll go on to yellow light disclosures. Okay, so this is kind of the bulk of what we're dealing with in mental health. I think we can all agree that a lot of what we do is in that kind of gray area. Black and white is not necessarily what we signed up for here. So a lot of the bulk of our situations when working with patients is going to be in the yellow light range. So a quote from FIPPA is that one may disclose personal information for the purpose for which it was obtained or compiled or for a use of consistent with that purpose. So this has been interpreted to mean that the information for continuity of care purposes on a need-to-know basis. So interpretation and healthcare provider judgment is often required. So this is a situation where it really is up to your clinical judgment and understanding of the situation about what is need to know. I think some things are pretty obvious, like previously mentioned, sexual activity, but then there are some gray areas that do require some clinical judgment and maybe even conversations with allied health professionals. I know for myself, working in the emergency department, I often have access to a social worker as someone to go and talk to about these scenarios. And it really is helpful to kind of talk through and understand what is the need to know, especially when we're talking about disclosing information to family or friends. So PIPA uses a reasonable person test, which means disclosure of information is authorized only for purposes that a reasonable person would consider are appropriate in the circumstances and that fulfill the purposes for which the information was collected. So essentially what this is saying is that if you ask a question about 10 different people, they're all going to say that was a reasonable piece of information to be sharing, not a situation where 10 out of 10 people would say, no, that's not reasonable. That would be something that we wouldn't want to be sharing. So an example of this would be an 18-year-old patient being transitioned from adolescent to adult services. Clinicians provide handover to the newly receiving team. All right, and then we're going to go into red light disclosures. So a quote from FIPA is that FIPA mandates that information must be disclosed when there is risk of significant harm to the environment or to the public health and safety of a group of people or the public. So examples of this are when there is a suspicion that a child is in need of protection, and that when there is risk of serious harm towards themselves or to others. So we did put in here and we did specify the risk of serious harm. So this is a conversation that we often have as a team. There are a lot of things that young people will do that are harmful to themselves. Think of something like self-harm or using substances. But for the purpose of disclosing or breaching confidentiality, we do want to ensure that this is something like a serious harm where there is going to be something that could potentially affect the patient in a serious way versus something, although self-harm is very concerning, we do want to address that, but it is not necessarily something that we need to disclose to something like MCFD or to a parent directly. So just a side note on here, anyone with reason to believe a child is being abused or neglected, or is at risk for abuse or neglect where the parent is unwilling or unable to protect them, they have a legal duty to report that concern to a child welfare worker in MCFD or to a delegated Aboriginal agency child welfare worker. So this is more so related to the MCFD after hours, ensuring that you are contacting them if there is a concern. And then another note on here is that proof is not required for reporting. MCFD is obligated to investigate all allegations. So as a clinician or healthcare provider, it is not your job to determine whether or not the person is telling the truth. It is your obligation to report this information. Another note on this is that often I see in the emergency department as well as acute care settings is that often people will defer to the social worker to be making these reports, but just know that if you are the person that received this information, so if you're in the process of doing an intake assessment or an initial assessment and there is some information that is disclosed that you do require to breach, it is not appropriate to go and ask the social worker to relay the information. You are obligated as the person taking the information to then report it to MCFD. So this sometimes is a miscommunication often that we rely on social workers to be contacting, but it's actually anybody who is taking the information that are required to report. Okay. All right. Any questions before we go on to the discussion scenario? Okay. So we have a couple examples of different scenarios. And so what we're going to do is, if it's easiest, maybe if people can just throw it into the chat, is you're going to determine if this is a red light, yellow light, or green light disclosure. And if it is a yellow light, you're going to specify what pieces of information would you maybe question or be hesitant about, or what is the nuance maybe in this scenario that you would need to know information about in order to determine whether or not you're going to disclose. So the first scenario here is that a patient who is 24 is being admitted to the inpatient psychiatry unit for an intentional overdose of Tylenol. She doesn't want her parents, who live in Mexico, to know any information about her admission. So either by shouting it out or putting it into the chat, what kind of disclosure do you think that this would be? So I see Monica has said red light. Yep. Chandra, red light. Yeah, red light. Red light. Great. So we're all in agreement. So this is a scenario where she is over the age of 19, so she is an adult. By the sounds of it, her parents might not have a lot of involvement in their care, and they're also living in Mexico, so I'm not sure how much involvement they possibly could have. And she's requested that the parents not have any information. A really key piece of this conversation with the patient, though, would be understanding who they do want information to be shared with, because we do want to ensure that there is a safety plan in place that revolves around the patient having access to someone that they can talk to or someone that is trusted. So really trying to understand the support network for this patient. So although we do not have any obligation to share with the parents, and this is a red light of disclosure, it would be a further conversation with the young person just to understand, do you have any friends that you can talk to? Is there a family member that's here, or an aunt or an uncle or somebody else, a teacher if you're in post-secondary? So we do have an obligation to make sure that we are ensuring that there is kind of a safety plan in place for this patient, but this is a red light disclosure. Okay, number 2. So a patient, 14, discloses that they blacked out drinking alcohol last weekend and crashed their bike. They are here in the hospital for a sprained wrist. So either in the chat or shouting it out, is this a green light, yellow light, or red light disclosure? Hey, Janice says yellow with a question mark. Okay. Yellow light needs some more information from Monica. Yeah, yellow. Okay. So maybe I'm going to put you on the spot, Monica, but what more information do you think that you would need in order to decide whether or not you were going to disclose this to the parents?
I'd need to know what the 14-year-old's thoughts are on talking to the parents, because it says nothing in there about, it could just be simply they don't want the parents to know that they crashed their bike while drinking, but they want their parents to know about the treatment for the sprained wrist. So kind of getting more information that way, but then also finding out if at 14 they are able to make those kind of treatment decisions for themselves.
Yep, great. Yeah, that's exactly what we were looking for. So some of the things that I would talk about in this scenario is this the 10th time that they've been in hospital for something like this, for maybe a substance-induced accident, right? If they have a frequent history of this, is this a further conversation? Do they want their parents to know about this? Are they involved? Are they not at the hospital yet and we're calling them to come in? So if it is a situation where they say, you know what, I don't want my parents to have access to that information, but I do want them to know that I have a sprained wrist and I do want them to know the follow-up from that, then we are within, the ability to protect that information. So we are not obligated in that scenario because they are here for a sprained wrist. But once again, it does come back to those nuances. Like I said, if this has been the 10th time that this has happened, then maybe this warrants a further conversation. But for the purpose of this example, we would say that this is a red light of disclosing the alcohol use if they declined to have their parents involved in that piece of information, if that makes sense to everyone. And please feel free to put your hand up or ask any questions if my explanations are unclear or if you have further questions. These are pretty unique scenarios that I have encountered primarily in the emergency department. So I'm happy to kind of talk through them, because that is, once again, an important thing about confidentiality is that it's not necessarily up to just us to make that decision, that we do have the ability to talk to others in these scenarios as well. Okay, so we'll go on to the third example. So a patient, 23, is being discharged from the inpatient psychiatry unit to his parents' home where he lives. He was admitted for psychosis and paranoia related to his parents poisoning his food. So would this be a red, yellow, or green light disclosure? Yep, Monica says yellow light, yeah. Yeah, it says yellow, yeah. So I would think that this is probably, and Bryce says yellow. Yeah, great. So we did purposely try to make these a little bit challenging, and just so that we could go through some of the nuances of these scenarios. So I think this is a really common scenario where we do have someone that is experiencing either their first psychotic episode or just a psychotic episode in general. And they are being released back to their parents. And so we did try to make the ages quite specific. So a 23-year-old, they're an adult, they can make their own decisions. But that being said, he lives at home with the parents. He previously has had paranoia around them poisoning his food, and he has a recent episode of psychosis. So some of the things that we would want to be sharing with parents under the continuity of care, as well as the need to know, would be something about either medication. So is this patient being discharged on medications? Is this patient being discharged on medications with the plan to start a new medication? So did we change a medication in hospital? And the parents need to know that information. So what side effects can they expect from the medication? And also, if we are looking at changing medication, a huge piece of that information is what symptoms can you expect if the medication is not working? So are they going to start to have paranoia again? Are they going to stop sleeping? Are they going to exhibit symptoms of psychosis? It would be important for their family members that are living with them to know this so that they can watch out for those warning signs. If there's any treatment plan, so are they going to be followed by something like the EPI team or an adult mental health team? What does that look like? When is their next appointment? Do they need support getting there? So these are all questions as a clinician that you would need to understand. If they've cleared from their psychotic episodes, they're reasonable, they're able to make it to their appointments on time, they've shown a history of being able to organize their life in that way, then maybe the parents don't necessarily need to know all that information, and we can allow the 23-year-old to make those decisions. But if this is someone who has notoriously been not showing up for appointments or has difficulty even on like organizing their day or getting that support on their own, then the parents would want to know that information. It would be helpful if they knew when their next appointment with the EPI case manager is, or if they're followed by a psychiatrist. So these are all different pieces of information that would be important, and you are able to share as a clinician under the continuity of care and need to know. Any questions about that? Yeah, I see, Chandra, you have your hand up.
Yeah, what if in this scenario, like the patient had disclosed any homicidal thoughts, for instance, towards the parents, then I mean, do we have the duty to warn in that situations? Then
yeah, so we do have a duty to warn, and I think that can be really common. Like I've seen that quite a few times where some of their, maybe even some of their psychosis is like related to some of these homicidal ideations. So we would have an obligation to not only report to the parents, but if we were actually concerned about a significant risk, we would likely need to disclose to the police. And then it would be a conversation with the parents or caregivers who's living in the home to ask a couple questions. Are there children living in the home? That changes the dynamic. Also, are the parents okay with them coming home? I see this really frequently where if this is like the third episode of psychosis, parents sometimes are really resilient in that way. And they'll say like, you know what, like we know what the signs and symptoms are. Like as long as they're doing really well, like we'll take them home, we'll monitor for these side effects. Like we're okay with them coming home. Or it may be a situation where maybe this is the first episode. They're really scared. They don't know what to expect. Maybe there was some physical violence that led to them being brought into the hospital. And the parents say, you know what, like we don't feel safe with them coming home. So then that becomes a different conversation, right? We would want to have social work involved. We would want to have a team involved. What are we going to do for this young person? Is it that we're finding them alternative housing? Are we keeping them in the hospital a little bit longer to ensure that their medication is working? And then having those visits with families so that they can see that they're doing better, and maybe making them more comfortable for that discharge plan. So that could be the difference of maybe a 3 to 5 day admission, but at the same time, then we're allowing the patient to possibly return home, which is ultimately the goal here. We don't want to be trying to find alternative housing, but sometimes that is the option that we have, right? If parents are really feeling unsafe, or there's maybe a younger child in the home and they just say, you know what, we can't do that. And even MCFD might step in and say like, we can't do that as well in certain scenarios. So it would be important for the family to know that information. And it is one of those things where if we're dealing with suicide or homicide, those are a green light disclosure across the board for that specific piece of information. But great question. I think that comes up quite often. And there's quite a few nuances with that. So that was a really good question. Thank you. Okay, any more questions before we go on to the last example here? Oh, okay. So the last scenario here is a patient, 18, is admitted for an accidental drug overdose, and their parents are out in the waiting room worried about them. They say that they do not want to speak to their parents and are worried they will find out about their substance use. So would this be a red, yellow, or green light disclosure? So
this
we
is
did
deliberately a tricky one.
Say.
So don't be afraid about
Yeah.
guessing the wrong thing. Feel free to just give your best shot and we can talk about it as a group about what we think.
Yeah. So Monica says yellow, need to clarify exactly what can be disclosed, if anything. Yes, yellow. Yeah, Jenna says yellow. Yeah, so this was purposely, I think, the hardest one for for last. So when we're looking at this scenario, we have that challenge of their age, right? So they're not 19, but they're almost an adult. It's an accidental drug overdose. Their parents are in the waiting room. We don't really know anything about whether or not they want their parents involved initially, but they do say that they don't want you to speak with their parents and they're worried about them finding out about their substance use. So there's quite a few nuances here. So what I really would love for the takeaway for this scenario to be is the importance of confidentiality not being a one-time conversation. So when you go and you do your initial assessment with this young person, you do have the obligation to make your confidentiality statement and then understand what it looks like to breach confidentiality. But when you are talking with them and you have the parents out in the waiting room, say this is a situation where they live with their parents and they're out there worried, you do kind of have an obligation to talk with the young person and say, I went and I spoke with your parents. They're really worried about your safety. Mom's out there crying, dad's really worried, and bringing that back to them. So in my experience, often when I do say that, patients will often allow them to come in and have that conversation to understand what went on, because a lot of the time they're just really worried about what's going to happen. Are they going to ground me? Are they going to take away my phone? I'm not going to be able to see my friends. Graduation is coming up. Those are all things that are going through the young person's head. And if anybody here is a parent, I'm sure you're all probably thinking the same thing. You're just glad that they're alive, right? Like you're really worried about their safety and you just want to know that they're okay. So sometimes it's an important reflection piece for you to talk with the young person and let them know, like, hey, like your parents are really worried and they're out there. Like, can I let them know that you're here and that you're safe? Like, are you okay with them coming in? I haven't had to share any information with them, but like we can have a conversation about what you do want shared. So for the purpose of the accidental drug overdose, we don't necessarily need to share that they were using drugs. We don't necessarily need to share that there was an overdose. And for the piece about them not wanting to speak to their parents. So often this is misinformation that if someone says you're not allowed to speak to my family, that you just don't speak to the family members at all. You are able to gather information from a family. So if a parent is sitting in the waiting room and they would like to provide you information that is something that is direct to their care and would be important for you to know, you are allowed as a clinician to gather that information. You are not allowed to share information necessarily, depending on what the patient has said, but you are allowed to take in that information on a continuity of care and need to know basis. So things about maybe their diagnoses, current medications they're on, allergies, those would all be really important things for you to gather from a family member. And then another part of this conversation would be possibly if the dynamics are appropriate. So for example, if a parent came in and they were screaming, shouting, and really angry, would that be somebody that we would let in to talk with this young person? Probably not. But if the parents are acting appropriately, if they're concerned, they are showing up appropriately, and the young person is willing to have that conversation with them, then we do want to encourage that so that we can look at doing some form of a plan when they do leave here so that parents are able to support them. So like I said, we did purposely make this one really difficult. There's a lot of nuances here. We didn't give you a lot of information, but we do just want to kind of foster that understanding of that there are certain questions that we can ask, and that confidentiality, once again, is not a one-time conversation. It's an ongoing conversation during your entire interaction with the young person as well as their family or caregivers. Are there any questions about that before we move on to the next section?
I do see one in the chat from Margot.
Oh, what if this was a fentanyl overdose and naloxone use? So this would be, and then I see another hand. So this would be, so regardless if this was, say, a Tylenol overdose or an accidental fentanyl overdose, we would not still be obligated to share with the parents. What we can do, and what I always say when we're dealing with families, if we're talking about substance use, that does not mean you cannot teach families about naloxone use. That does not mean that you cannot do a safety plan with the family without disclosing that information. So often the way that I go about this when I'm talking with the family, if the young person has said, I don't want them to know why I'm here, I don't want them to know I use drugs, I don't want them to know that I overdosed, you can still have a conversation with the family about safety planning. So I always say to families, these are not necessarily things that is going on with your young person, but I always talk about them with all families with children. Like, under the age of 19 or somebody that's under the age of 25. And that would be like examples would be making sure that medications are locked up, that sharps are kept in the appropriate location, cleaning products are used in appropriate ways, and going through and offering Narcan teaching if they're interested and having access to a Narcan kit. So we're not disclosing the information about why the patient is there, but we are providing family members with the tools to support the young person if they need that. So some families may assume based on the conversation, but if you do phrase it in a way that says, I do this for all my patients, not just the ones with mental health concerns necessarily, then that is a way that you can get kind of around that confidentiality piece while still making sure that the parents feel competent and not as worried caring for their young person. Does that answer your question, Margot? Yes, I see a thumbs up. Okay. And then I think Chandra, you have your hand up.
Yeah, just I don't know if you want to take the time to answer it, but I'm just curious if it was this scenario and it was actually an intentional drug overdose and the patient was actually saying, expressing SIs and was saying, you know, I'm going to go out and do it again as soon as I can, kind of thing. In that case, I mean, I'm guessing that client potentially would be certified for risk. And then, like, is there an obligation to inform parents at that point?
Yeah. So if this was a situation, so keep everything the same, and then instead of an accidental drug overdose, it would say an intentional Tylenol overdose. We would, and if they're saying, I'm going to go do it again, things or something along those lines that make you concerned that they will go out and try to end their life possibly in a different way. One, this would very likely be a patient that would be certified. I would imagine, unless there was like a very strict care plan or some sort of historical presentations, familiar faces care plan, that we would be certifying this patient. So then that would come back under the Mental Health Act. So when we're completing the form, so the nomination of a near relative and notification of a near relative, it doesn't say that we have to disclose all of that information. We just have to notify them that they are involuntarily certified. So how this works is that the young person can decline to have their parents be the people nominated. They can notify somebody else if they would like, but if they refuse to have anybody on the paperwork, then we are within our right to use the next of kin listed on their chart. That generally will be a parent, and we can fill out that information. If they refuse to have their parents involved, there is no next of kin on their chart, then that is when we would go to the public trustee. So we would notify them via letter that this patient has been involuntarily certified under the Mental Health Act. So that would be kind of the process for that. Generally what would end up happening, because we are talking about risk of self, we would be obligated to disclose that as the rationale for the certification to the family if they are the people that are notified. So it wouldn't be necessarily all the details, but it would be to say we are concerned that they are at risk for hurting themselves via suicide, and we do need to have them certified under the Mental Health Act in order to ensure their safety. Would be kind of a conversation that would go about that way. Does that answer your question, Chandra?
Yeah, that's great clarification. Thank you. And especially that you still wouldn't even have to mention the drug overdose piece, but it would just be around risk to self. Yeah, thanks.
Yeah.
I will just add, from a community perspective, which is mostly where I've supported youth with mental health, if there wasn't a hospital admission and certifying being looked at, something like a serious harm to themselves or others, in this case, which there would be if they may be looking at trying to harm themselves or end their life, absolutely, that's a green light disclosure right there. So even without a certification, there would likely be involvement of the family with some safety planning to ensure that we can keep them safe in the community. A key strategy I think Steph does really well in her work is if the young person at first is really hesitant about talking or involving the family, just asking, hey, can you tell me more about that? What are you worried about? Are there any specific things that you're worried about in relation to what your family finds out? And often you'll find out they're okay with you sharing some information with family and just really being clear with them about what they don't want shared. And so, like Steph said, an ongoing conversation, but often they will be more kind of open to that if they realize that some of that information can be kept safe and that you're here to kind of listen to what their concerns are.
All right, so I will throw it back to Sarah to go through some strategies.
Great. So we've talked a lot about, some of the confidentiality policies. Again, all of us are in different professions. And so in addition to things like FIPPA or the Infants Act or the Mental Health Act, we all may have different confidentiality requirements based on our college or on our profession. And so, of course, continue to follow those in relation to what we've talked about today. And we recognize that we all may have different guidelines there. But in terms of engaging with families, for those of you that have attended our training before, you'll notice that some of these strategies we talk about are not very different from strategies that we use to engage with youth in general. And so some of these may very well be reviewed, but we really just want to highlight some key things that we found have really helped working with families and working through that resistance or those differences in belief around what a treatment might look like or what care might look like. And so just some general strategies to build trust with families. One of the first things I like to do is really make sure I understand the family's beliefs and expectations of mental health care and ensure they have accurate information. If they're coming in and they've Googled their child's diagnosis and have some ideas about what they think the diagnosis is, or they've maybe heard some things, this is a really helpful time to provide them some accurate information or point them to some resources. If there are some websites like Kelty that give really clear information about a diagnosis of a young person or medications, and the beliefs and expectations of mental health care, just making sure that their expectations might be realistic for the setting we work in. So with the emergency department, right, setting those expectations with parents that they likely will have quite a short stay and they'll either be transferred to another care setting or they'll be transferred with a lot of mental health care being done in the community, just so that family isn't flabbergasted or upset when that young person is diagnosed to community quicker than what the family thinks might have been happening. And also beliefs around healthcare in general and around mental health. Do they have any kind of fears or beliefs where they don't feel comfortable with medication? Is mental health something that's talked about in their household? Is substance use something that is an acceptable topic to be talked about, right? This can look really different across different experiences, backgrounds, beliefs. And then using layman's or just everyday language when we are doing any education. So just like how we all do patient education, caregiver or family education can be huge and helpful in reinforcing some of this. So again, I've already talked about potentially helping to unpack or explain a diagnosis further if they're still processing and having questions, or helping to understand timelines in whatever care setting they're in. Honesty is a huge one here as well, right? We don't want to give unrealistic expectations of what's being provided. We want them to understand that there may be wait times, limitations of the mental health system. Empathy is huge here, right? Acknowledging the difficulty of this process on a family system for everyone involved. And I'll get more to that in the next slide. Integrity, so doing what we say we're going to do and not making promises we might not be able to keep. And then foundational knowledge. So in our areas of work, whether that's substance use, pediatrics, adult mental health, just having that foundational knowledge so that we can help to provide that education to parents. And most importantly, saying, I don't know if we don't know, and finding someone who does. So, letting that family know that you want to make sure you're giving them the best answer and you can always get back to them and you don't need to have the pressure to know that answer in the moment. In terms of some other strategies, empathy. This sounds really obvious, but this may be one of the scariest and most stressful days in a caregiver's life, and they may not be showing up as their best self, right? How many of us, if we were having one of the worst days of our lives and we were really stressed and worried about our child, do you think we'd be the best version of ourselves or the most pleasant? And so this can show up very differently for different people. This can be anxiety, this can be anger, this can be resistance, right? And this admission or intake may have been a long time coming, with a prolonged period of supporting their loved one and the associated stress or burnout leading up to it, right? Or this might be maybe the third or the fourth admission, and this has been a really long process for the family. Families can often fear judgment due to societal assumptions that poor parenting has caused or contributed to their child's mental health. So yes, in some cases, the dynamics in the family may be contributing to the young person's mental health, but we also know that this is a big stigma that many parents feel judgment about. We know parents get judged and given advice about how to parent all the time, and it's really important that we let them know, hey, we know you're doing the best you can. We're not here to judge. We're here to understand and support you. And this can really help them feel more comfortable and want to open up in the process. And it's really important to offer that non-judgment, that curiosity, that support. We're really there to listen, to understand, not to respond. Yes, we will eventually need to respond, but we really want to first validate the concerns they have so that they feel settled and heard before they're kind of ready to work in that partnership with us. So validation is a key part of this. So Validation, you understand where the other person is coming from, even if you disagree with what they say or do. And above all, you acknowledge that their experiences and feelings are important and valid. So things like, I hear what you're saying. It sounds like this has been a scary experience for you. That was a very overwhelming situation for you. I don't have the same beliefs, but I can see this is important to you. Particularly if a caregiver or family has been waiting a long time for you to come in to see them, there might be a lot of that frustration and just saying, hey, thank you so much for your patience. I'm sorry that took longer. But I just am here now and I really want to take the time to ensure that I can give any support that I need to give. Normalization. So ways in which we can help prevent, minimize, or reverse the psychological and behavioral manifestations of being viewed as different from society. So things like, it's really common for parents in your situation to feel scared or worried about self-harm. Or sometimes when people get really angry, they say things they later regret. Has that ever happened to you? So helping them understand that any parent in their situation would be feeling overwhelmed, would be having these emotions. And parents often say they feel like it's a sign that they've failed as a parent if their child is having mental health concerns. And we know that mental health concerns affect people all across the lifespan, and there's many factors. And so just helping parents understand it is normal for a young person to have some low mood and some anxiety, and we want to be able to support them through that, and they're learning their coping skills as part of their own journey they're on. And paraphrasing, so repeating back your understanding of the material that's been said by the person in your own words. So it's really just reflecting the essence of what has been said. But I find this especially helpful with parents to ensure that we are hearing things the same way that they're wanting them to be intended. So just checking our understanding. Things like, what I'm hearing is that you don't feel supported by your son's current healthcare practitioner. Or it feels confusing to navigate a system when you're being sent to multiple different clinics for the same concern. This also gives the parents time to say, hey, that's not quite it. What I'm actually trying to say is this, to ensure that you're on the same page in that conversation. Clarifying. So often parents might make a pretty sweeping statement, and it's important to ask a few more questions to understand. So open questions. Things like, when you say your child threw a fit, exactly what did he do? Or when you say you think they're manic, what symptoms are you referring to? Just to really check our understanding and understand what the parent is seeing or what they're getting at. And then the concept of a behavioral incident, this can be really helpful. It's a term used a lot by behavior interventionists, but across anywhere in parenting or healthcare, it really helps to highlight a single separate behavioral event with a clearly defined start and end. And it may be combined with other events to form a behavioral sequence. So what that means is you might be able to start seeing patterns in a young person's behavior. Maybe if they're escalating, there were some similar things happening before that led up to that, and it can really help understand how to support that young person and how to manage situations like that in the future to potentially avoid a pattern where that continues to happen. So some examples might be, talk me through this outburst. What time did it start? What was happening before that? This also can really help parents and clinicians build insight into some of the patterns or behaviors they're seeing with their young people. So in terms of engaging with families, we'll now talk a little bit about working through resistance, but I'll just quickly see if there were any questions or comments from anyone. I don't think I'm seeing any yet. I know a lot of those strategies are review, but we do just, like, it sounds silly, but we use those every day in our work with parents and young people and families. And so did not want to not highlight them still. So in terms of working through resistance, we really wanted this to be more specific to some of your experiences in practice. We know a lot of you work and are aiming to do family-centered care. So if anyone is comfortable sharing, and of course, being careful not to share too many identifying details for the confidentiality of the situation, but what is an example of a challenging situation you have encountered in the past or are currently experiencing with a young patient and their family? If there's anyone comfortable sharing, we thought we might be able to talk as a group about some ideas on approaches, strategies, or resources to navigate this. And feel free to unmute yourself or write in the chat, but we know that a lot of these situations are coming up, so just wanted to make a bit of space in case anyone wanted to talk through some of the challenges they're having.
I can share one where, hi everyone, my name's Otto.
Hi,
Can you hear
Otto.
me?
Yeah, we can
Hi.
hear you, Otto.
So just my experience working with family support, but also at Seagull with inpatient. It's a very challenging situations where families are caught in a catch-22, where they're reporting what they're seeing with their child's presentation or issues or behaviors. And then when they go on past, it might be going home. And so the physician will ask, how was the past? And the reporting. And oftentimes they're reporting things that the young patient might not agree with or might be frustrated with because they're not doing that well. So it sets up this tension and dynamic where I think this is what I hear from parents and also from care teams is that, um, having worked inpatient, the number one goal of the young person is just to leave the hospital, no matter what. And, they'll sometimes tell us what they think we want to hear, but sometimes the reality is different. So that sets up a situation where I think it's important to have collateral from both sides. And to really align with the goal is for recovery, and that it's not going to happen post discharge, but there's going to be challenges. And how do we help align the community care team to support the client and the family with that, and what would be the best care plan? So, it's understandable. There's real differences around like what the client and the family might be invested in. And that's going to be the hard part. And as many of you know, like most clients, when they leave the hut, they don't want to be on medications, especially young people where the medications make them gain weight. They might feel lethargic. So there's a real challenge around supporting treatment and what that looks like.
Yeah, absolutely, Otto. Thanks for sharing that. And I think highlighting the experience of a lot of them not wanting to take that medication or wanting to go off that medication right after hospital can be huge. April, one of our amazing nurses at the 2 West on the inpatient unit, she really emphasizes when she's working with a patient who's looking at getting discharged, she really gives a lot of education to the patient on some of the side effects, particularly things like the effects it can have on sexual performance, which can feel like quite a taboo topic, but it's something that affects people's lives and is a really key and very important thing for a lot of people. And so she really provides education on, hey, these are some side effects you may see, but just know that going off that medication abruptly out of nowhere can be really, really harmful. And so if you are having those concerns, really talking about that with your doctor and with your support network to make a bit of a plan if the medications aren't working for you. That other piece I think you highlighted was the tension between maybe with parents with the wanting to keep them safe and the anxiety, but then balancing that with that young person's desire for some of that independence when they're discharged, hey?
Yeah, well, it's the idea. I don't want to be back in hospital. But I don't want to be on medication, or I'm not sure about treatment. And so it's a really challenging period in recovery, right? Around what's going to work for that young person.
Yeah.
And I think sometimes parents are caught between knowing that whatever they tell the treatment team will frustrate or agitate their loved one, but they're trying to serve and support the treatment plan.
Yeah, I think this is something that you often see, especially on inpatient units, especially around passes. And say the pass didn't go well, like maybe, for example, the patient maybe left the home and didn't tell the parents where they were, or they went out and maybe they were drinking with their friends because they finally got a pass and they've been in the hospital for 3 weeks. But we know that these periods of passes and discharge and transitions are the highest time point for risk of something like suicide or unintentional overdose during these timeframes. So it is so important that we're making sure that there's that communication with parents, what to do if their young person does leave the home and doesn't maybe tell them where they're going. Who do you call? What do you do? Is there a time frame that you wait? And also giving parents the opportunity. I know when I worked on the inpatient psych unit, one of the things that we would do after passes is that we would check in with the patient and the family together. How did the pass go? Hear from both of them, and then walk the family out and have a private conversation outside the unit and say, hey, like, how did the pass go? Re-ask that question. Were there any challenges? Did you have any questions? Did they take their medication? So it gives them an opportunity to be quite honest with you, where the patient doesn't necessarily see them standing at the nursing station talking to them, or they're at risk of coming up and saying, don't tell them that, I don't want to talk about that. So often I'll see nurses that will kind of, okay, I'll walk you out the unit, kind of have a nice day, like, let's talk outside. And then it kind of gives parents that opportunity to have that conversation. And usually I'll say to the young person, you know, we do have an obligation as clinicians to make sure that you're safe, but we also know that when you're home with your parents, like, they also have an obligation to keep you safe. So although you don't want them to have any information, I'm not sharing anything, I do have an obligation to take that information from them just so that we know how you're doing. So often, sometimes I can find that kind of privacy for the parents as well, because how often do we see where the young person is maybe even blaming their parents? Like, you're the reason I'm in here. Like, I don't want to be here. I'm not going to tell you anything. Well, that's not really going to be helpful for the discharge plan, is it? If we don't know that they can trust their parents and provide that accurate information. So it does become quite a really common challenge that we see in hospital.
Absolutely. And I think, you know, from a therapy point of view, when you look at attachment, that it's easy to blame your closest attachment, right?
Yes. Yeah.
At the same time, it can also shortchange recovery. And the other piece I think a lot of us struggle with through treatment is this idea of insight, where you know, that is like the $64,000 formula. Like, how do you build insight in a young person who is still building insight, and how to be a young person, let alone a young person with mental health recovery. And that doesn't always come easily. So yeah, there's a lot of challenges, I think, in working with young people and their families, for sure.
Yeah, definitely. And I think this conversation today, there will be no way for us to ever talk about the whole complexity of cases. And I'm sure, despite understanding everything in the presentation today and all of the resources and knowledge you all come with, we're all still going to encounter situations that are really yellow, and we feel like we need to talk about them with colleagues and really think through them a little bit more. And so we hope this presentation just also highlighted that you're not alone in that, and that following those clinical instincts and leaning on the people in your team to help you with navigating these decisions. But at the end of the day, there is often a way to support the wishes of the patient while also promoting their safety and having some family involvement to the benefit of all. We are always available outside of these education sessions for consults if you are wanting to ask more questions, or if you have a specific challenging case with a family and a young person you're working with. That's a really big focus of our project. So please always reach out about that if there are more. For the sake of time, we will move forward for now. And so just in here is another discussion scenario that we didn't get to, but we much would rather talk about real situations you're all facing. So you'll see that in the slides if you do look at these later. Just wanting to finish with a quote that any family that shows up is a family you can work with. So just to do a bit of an overview of the strategies we went over, we talked about building trust, we spoke about validating, normalization, paraphrasing, clarifying, and empathy. Some of the acts we spoke through were the Mental Health Act, the Infants Act, and FIPPA. I'm not going to say the whole thing again because I can never say it properly without stumbling over my words. And at the end of our presentation here, we did just want to provide some clinician resources. These will be in our slide deck, which we'll share after the presentation on our team site. But just some different resources to help provide supports for parents, as well as a clinician to know things that are out there for family supports. And some parent resources as well. So some really helpful things to share with parents around evidence-based research or information on medications, on diagnoses, on some family support groups, on some places where they can also get support with service navigation. So the BC Schizophrenia Society, for any severe mental health condition, not just schizophrenia, they offer system navigation supports for serious mental illness, as well as some other resources here for caregivers, just to let them know they're not alone, and that really just showing up and doing the best they can is really all you can ask. And as parents, all parents or all caregivers and family are doing the best that they can at that time with the tools and the abilities that they have. So we'll leave a little bit of time now for questions if you have them. And our email is up here, missingmiddleproject@cw.bc.ca. So feel free to get in touch with us anytime. Our Missing Middle team site is linked in the presentation slides as well. And if you've ever emailed with Steph or I, in our email signatures, we always have the Missing Middle team site linked there. So just to close off, just wanted to thank you all. I know that this is a long time to be sitting listening, especially with all the amazing work you're all doing. Taking time out of your busy days to come to education means a lot and just shows that you're really committed to doing this work and working to include and integrate families as much as we can in care. There is a quick post survey. This really helps us understand if these education sessions are touching on the things you're hoping to see, and also really helps us understand whether we've had some impact today. So please feel free to fill out that post survey. Should only take a few minutes, and there's a chance to win some Starbucks gift cards if you fill out the surveys. So we'll sit around for the next probably 5 minutes to allow that post survey to be open, but please jump in with any questions for Steph and I if you'd like to as well. Thank you.
Thank you, everyone.
Thank you.
Thank you.